Welcome to the video covering physical therapy management of coronary artery disease. We are going to focus on angina and myocardial infarction. You should have already reviewed cardiac pathology and cardiac diagnosis and surgical management prior to this. We're going to start reviewing the initial or acute response to exercise, in other words, the changes that occur as soon as you start exercising. And we're also going to review the long-term changes that occur after someone has been training or doing aerobic exercise for a number of weeks. And we're just going to review a lot of the efficiency that the body creates. And then finally, we're going to focus on describing the three different phases of cardiac rehabilitation that a person would go through if they've had an acute MI, a PTCA, or a coronary artery bypass graft. So if you just take a quick look at this visual, this is looking at the acute response. And it's a bit complex, but what we have here is the heart rate change on top, and then systolic blood pressure and diastolic blood pressure. So if we look over time as the person is first doing submaximal exercise and then more of a maximal effort and then their recovery, no surprise I'm sure to you that their heart rate is going to go up progressively. Once they hit their maximal effort, that heart rate's going to plateau because the heart rate can't keep going up if they've reached their maximal ability. And we kind of touched on this concept when we talked about the concept of stress testing. And then of course, once they've stopped their physical activity and they're resting or recovering, then the heart rate is going to go back down until it reaches their resting level. Now with blood pressure, for the systolic blood pressure, we do see a slight increase. As the muscles are exercising, we need a little bit higher blood pressure in order to make sure that we're able to perfuse oxygen out into those exercising tissues. So we do see a slight elevation in the systolic blood pressure, and of course recovery to normal once the person stops activity. We really see very little change in diastolic blood pressure. So if you're seeing somebody exercising, you're seeing a big spike or a huge drop in their diastolic blood pressure, that would be kind of a sign for concern. But the normal response is just really a very minimal change. So if we look more specifically at our cardiovascular response, remember this is engaging the sympathetic nervous system. So that's going to create general vasoconstriction in the tissues that they're not using, and general vasodilation, again, in the muscles, the heart, and the pulmonary system. We certainly are going to see dilation of the coronary arteries so that we can get lots of blood flow to the heart that's working harder. So we're going to see heart rate and stroke volume go up, cardiac output's going to go up, and that's going to be, of course, what supports the working tissues. In addition, as I mentioned, we're going to see an increase in the systolic blood pressure so that we can push that oxygenated blood out into the tissues, and pretty much not really a big change in diastolic blood pressure. Respiratory response, of course, increased rate and depth of respiration so that we can oxygenate that increased blood flow that's going to be moving through the pulmonary circulation. And then at the muscle level, we expect to see fairly immediate changes in the chemicals and the hormones that allow oxygen to be offloaded from the hemoglobin in the blood vessels onto the myoglobin in the muscles. Now when we are looking at someone who's been training for a while, so more at the long-term response to a sustained or a training type of aerobic activity, then we're really looking at those more permanent or more sustained changes that result in a lot of efficiencies. So as with any stress, if we did strengthening exercises to the extremities, we'd expect the muscles to hypertrophy. Well, here we're essentially doing strengthening exercises for the heart, so we expect to see the cardiac muscle hypertrophy and become stronger. So the response to this, of course, is with every contraction, every beat of the heart, or during systole, since the heart's stronger, it's able with each beat to eject more blood out into the aorta and then to the body. So that gives us increased stroke volume. And we definitely see this change at rest, so that at rest, when the oxygen demand is low, the heart's really strong. With every beat, it puts out so much oxygenated blood that the heart doesn't have to beat quite as often. And so we see that decreased heart rate at rest. And we also see that it takes a lot more activity or exertion to get the heart rate up there. And you've probably experienced this yourself if you first start a running program or an aerobic program. Your heart's just beating out of your chest when you first start it. But then as you become more trained, you can reach higher levels of exertion with subsequently lower levels of heart rate. Some of this can be genetic as well, and Lance Armstrong is kind of always used as the example that he always had a little bit of a lower heart rate, but with training, his resting heart rate actually went down to the low 30s, and he still had a very normal cardiac output, meaning he produced the same amount of blood volume per minute as a normal guy his age and size would, but with very few less beats of his heart, so indicating his heart was very strong. Remember, the other thing that we said when we did the normal anatomy is that the only time oxygen can diffuse into the heart muscle itself from the coronary arteries is when the heart is more relaxed or during diastole. So if there are fewer periods of systole, that means there's longer periods of diastole, and so that gives the coronary arteries a lot of time to diffuse oxygen into the heart, and that also is a really good efficiency response. When we look out systemically into the peripheral circulation, we see more capillaries going to the muscles that are typically used for the aerobic activity. So we see here some specificity of training. The muscle groups that are used for a specific aerobic activity are going to be the ones that get more capillaries. But in general, we will see generalized metabolic changes and enzymatic changes that allow for a much more efficient transfer of oxygen from the vascularity into the muscle tissue. We also see an increase in rate of skeletal muscle metabolism. So in other words, it can burn fuel a lot faster, and so it can produce the energy that it needs for the response. Generally, we see a reduced in blood pressure. We see higher blood volume and higher number of red blood cells. So we have more capability to carry oxygen out to the tissues. This in turn gives us an increase in VO2 max, which is the maximum aerobic capacity. Certainly, nice benefit that a lot of people are looking for is to decrease their body fat and increase their lean body mass. We would like to see, from a health perspective, decrease those blood lipid levels. We know that's one of the risk factors of coronary artery disease. And then finally, another risk factor for coronary artery disease is stress, and we know exercise can be a good way to diminish stress. So all in all, with a sustained aerobic exercise, we see a lot of benefits to those very risk factors that put someone at higher risk for development and worsening of their coronary artery disease. So exercise is a really powerful treatment. And then we can see here with this illustration some of the other advantages of regular exercise. And I'll just let you look at this for a minute. Okay, well, I want to go on and talk about the 3 phases of cardiac rehabilitation. And you might be aware that in some settings, physical therapists aren't even involved in cardiac rehabilitation anymore. It's done by exercise physiologists, nursing, or other differently trained people. But there certainly are areas in which physical therapists and physical therapist assistants are participating in standardized cardiac rehab. The other thing I would say is that you may well see patients after they've had an MI, a stent, a bypass, and they aren't referred to cardiac rehab because maybe their status doesn't really allow them to do that, their medical status. So I would say I saw a lot of these kind of patients who got sent to subacute rehab if they were a little bit older and they couldn't have tolerated going home or going to an outpatient setting. So you may well see people who could benefit from following these guidelines, even if they're not in a traditional cardiac rehab program. So the first phase that we're going to see is phase 1, which is the inpatient. And I want to go through the goals, and then we're going to talk about the level of activity in each phase, and then we'll talk about how we would progress them through those levels of activity. So goals in inpatient are to prevent deconditioning. So we're not trying to increase aerobic conditioning, we're just trying to prevent further deconditioning. So this is very much an acute type of approach. So just like in an acute phase, we wouldn't try to strengthen someone after a musculoskeletal injury. In the first phase of cardiac rehab, after an MI or stent placement, we're not trying to increase aerobic capacity. We're just trying to prevent them from losing the ground they have. If they've had surgery, we want to prevent any postoperative complications like pneumonia, DVTs, things like that. We really need to get a handle on how they are responding to aerobic activity, so that's part of what we're going to do. And a big part of the first phase of cardiac rehab is just to educate both the patient and the family so they understand the disease process, they understand the risk factors and how they can be modified. We provide a lot of support because anytime you're looking at changing life habits, whether it's an eating habit, an exercise habit, a smoking habit, takes a lot of support and a lot of education to help people make those changes. We want to make sure they're really clear on their guidelines for activity and how to conserve energy while they are still recovering. And then, of course, we want to make sure that they understand how to monitor their own heart rate, their rate of perceived exertion, and then any other symptoms that might indicate that they are exceeding the activity levels. So again, those might include angina, dyspnea or shortness of breath. We'll talk about weight gain and lower extremity edema related to heart failure at another time, as well as the increased pillows for sleep. So a concept I want to introduce to you now is the concept of metabolic equivalence, or MET level. And the formal definition of 1 MET is the energy that's required just for basic cellular function while the person's awake and in a sitting position. So my guess is all of you are awake, here's hoping, and in a sitting position. So you are probably operating at about 1 MET level. Maybe a little bit more if you're typing or texting on your phone or doing something else while you're listening, but you're basically operating at about 1 MET level. So what that means is for every kilogram of your body weight per minute, you're using 3.5 to 4 milliliters of oxygen. So let's think about that again. It's 3.5 to 4 milliliters of oxygen for every kilogram of your body weight every minute. So it's basically a MET level is a description of how much oxygen you need to burn energy at a certain level of activity. And the reason this is important is because we are going to be looking through these different phases. Of course, the more oxygen the more activity you do, the more oxygen you need to burn. And so you can see from the table here that MET levels or MET requirements go up the heavier the activity. So right now, again, anything less than 3 METs, let's look under the occupational, sitting, doing some clerical or assembly, or as I said, if you're typing, you're probably in the 1 to 2 MET level, doing some desk work, that kind of thing. So we'll go through this, but that's what a MET level is. And so in this phase 1, we are progressing people from 1 up till about 5 METs. And so if you look at the types of activities, especially on the physical conditioning, they're going to be doing some walking at not more than 3 or 4 miles an hour, maybe sitting on an exercise bike. So light calisthenics would be active exercise. That's the kind of thing we're going to be doing. So for example, if we were seeing somebody in a hospital setting, let's say after they had a coronary artery bypass graft, we would start them, if we're doing extremity exercises, from maybe active assisted to active exercise and maybe some light resistance. We know that if we do wrist flexion and extension, it takes a heck of a lot less work than to do shoulder flexion and extension. Or ankle pumps are a lot less than doing side-lying hip abduction. So we generally would progress them by doing more distal exercises and then working those proximally in the extremities. We also know it's more effortful to do trunk activity. patient position also plays a role. So if the person, let's say you're going in again to a hospitalized setting, first day that you're seeing someone, or the physical therapist has seen them once and now you're seeing them, you're probably going to start with them doing some light exercise just in bed, the head of the bed raised up a little bit, or maybe sitting in a bedside chair. And then from there you might be sitting on the edge of a bed and then doing some standing activity. And then finally you're going to be thinking about how to get them moving around, so you'll kind of go from just transferring to a bedside chair to ambulating, and then ultimately to maybe doing some stair climbing so that they can go home. So usually this phase 1 is occurring in an inpatient setting, and we're trying to get the person ready to be able, hopefully, to go to some form of residential setting, whether that's home or a rehab setting or a subacute rehab setting. So since we can't do a lot with these people, we tend to see them for shorter periods of time, a couple of times a day. Very important to do constant cardiac monitoring. This is part of us making sure that we know if they're tolerating the activity and how to progress them. So many of these people are going to be on telemetry, which means radio, like a portable, they'll have EKG monitors on, and that EKG information will get sent via radio waves to a central monitoring station. So someone will be monitoring their EKG and their heart rate, but that doesn't mean you shouldn't be monitoring heart rate as well. So a pulse oximeter is a great way to do that. You can monitor oxygen saturation and heart rate. You should be asking them what the rate of perceived exertion is. As a way of educating them about their symptoms, you should be asking them about their symptoms and helping them understand that. So for rate of perceived exertion, that should stay in the fairly light area. Another way to make sure that you aren't overtaxing somebody in this first phase is to make sure that you have assessed their resting heart rate and then not work them more than 20 beats per minute over that resting rate. So if you're seeing excessive shortness of breath, if they're having complaints of a lot of fatigue, if you're seeing paleness or excessive perspiration, any kind of dizziness or incoordination that's showing excessive fatigue, certainly those are all signs that they're doing too much effort, and they should again also be educated in these signs and symptoms. So that's phase 1, again, generally an inpatient type of setting, or you might be seeing somebody maybe in home care. That kind of falls into that phase 1. Phase 2 is considered usually outpatient setting, so usually about 2 to 12 weeks after whatever cardiac problem that they had. So this could be outpatient, but it could be a subacute or an inpatient rehab setting as well. And as I mentioned, you might not be seeing somebody in a classical cardiac rehab setting, but you should know what they can do and what should be expected of them at this time frame after an MI or a heart bypass or a stent. Person still requires really close monitoring and supervision during exercise, and if they are in a traditional cardiac rehab, then they're going to be taking classes. They'll be doing a lot of group activities with other people at the same time, so that provides really important social support, particularly for some of those changes in their lifestyle that we talked about before. So overall, we're trying to improve their functional capacity so that they can resume their full life activities, whether that's just, maybe there's somebody who's retired, they want to be able to do their home activities or their yard work. If there's someone who's working, they certainly want to return to work. So we want to get them back into whatever normal household and work and recreational activities that they normally do. In addition, again, we're trying to really promote these lifestyle changes, which can be challenging, quitting smoking, changing diet, incorporating and maintaining an exercise program. Those are all things that if everybody did naturally, we probably would see a lot less patients with coronary artery disease. So the activities, certainly from an aerobic standpoint, treadmill and bicycle, exercise bike are really common types of things. Upper extremity ergometer, remember, is the hand bike. We'd also want to do some strengthening with weight training with them And as I said, education and motivation are important. So the MET level range now, we got up to 5 METs with the phase 1, so we're picking up there and going up to about 9 METs. And you can see, again, on the table, some of the activities, and particularly if we look down to the physical conditioning, they're walking pretty briskly. 4.5 to 5 miles an hour is about as fast as you can walk without starting to jog. So you might be moving into jogging, bicycling, bumping up to 9, even up to 12 miles an hour. They may be in access to a pool, or you might be in a setting that has a pool, or again, some other types of exercise machines that they can use for aerobic activity. We would use our typical, we are trying to increase their aerobic capacity, so we would use our typical protocol for aerobic activity, which is to have a warm-up time of 5 to 10 minutes, get them up to their target heart rate for 20 to 30 minutes, and then a cool down of 5 to 10 minutes again. So we would be expecting that this would occur at least 3 days a week, and we certainly would love to see them do this 5 days a week. We know that the more frequently we do it, the quicker we're going to get them up to training while they're improving their aerobic capacity. Once they have attained the level that we want, then they can maintain it pretty easily at 3 days a week. I do want you to spend some time also looking at some of the associated activities, because another thing you're going to be doing is giving them guidance as to the non-exercise but other household type activities or lifestyle activities they can do. So should they be going up and down the stairs? Should they carry the laundry up and down the stairs? Can they work out in the garden? You know, what can they do at work? These are all questions that you can get some guidance with by looking at the table and getting some examples of other activities that would fall into the 5 to 9 MET range. So finally, in phase 3, they've definitely completed, they've regained their aerobic capacity, and so now the basic goal is to help them maintain that capacity and their function, and also to help them really develop that lifelong habit and commitment to physical activity, as well as the other really good, healthy life choices that hopefully they're making. So this is something that's pretty much done on their own. This isn't any longer in a formalized setting, but they, by this point, should have maybe a variety of aerobic activities that they like to do, and they should be continuing that. And again, as I mentioned before, minimum 3 days a week to maintain. They certainly could do more. So at this point, we are finished with the lecture portion. You have a separate lab sheet, a cardiac lab sheet, and at this point it would be appropriate for you to start going through the lab activities 1 through 6. And we will be discussing those together as a group in class. You're certainly welcome to work on them in groups as well. It doesn't have to be independent activity, but lab activities 1 through 6 would go along with the information that we've covered up to this point. All right, thank you very much.